Welcome to the APAPP broadcast. We're here at the second annual National APAPP conference here in Nashville, Tennessee. My name is Jessica Glennie. I work at the Cleveland Clinic in Cleveland, Ohio. I work with the interstitial lung disease team here, and I'm joined by some of my colleagues.
Hi, my name is Amanda Mixon. I'm actually a rheumatology APP. I've been in rheumatology for 18 years, and I practice in Colorado for a large healthcare system.
My name is Cori Fratelli. I'm a nurse practitioner. I practice interstitial lung disease at National Jewish, and I'm very excited to be here at the APAPP conference and to have this discussion with my colleagues.
So, Amanda, you had a session here at APAPP about rheumatology in the lungs. Can you briefly summarize for us, the key takeaways from your session and what you hope attendees will apply in their practice from this?
Yeah. So first, I'd just like to start by saying, I feel like cross collaboration is so important, right? Like we all learn really, really well from each other. And having this experience with RAP at the RAP conference, we find that attendees really, really like those sessions. So we always bring people like yourselves to teach us about pulmonology. We bring different specialties as well so that we can kind of gain some additional information about what they're doing, what things are important. So I tried to kind of bring that to this session, which is all about rheumatology and the things that I would want to know if I were a pulmonary APP. Now, obviously, from that perspective, I totally understand that I don't know a lot about what you all do. That's why I learn so much from you guys when you come and teach us. But, I felt like as I've kind of talked with some of your colleagues, they felt like labs were really important because in rheumatology, we love labs, probably more than most things. We love our labs. And so, I'm sure you guys love your imaging, right? Like your CT scans and your pulmonary function tests and things like that. We love labs. And so I felt like that was important because different autoimmune diseases that commonly impact the lungs, there are certain labs that go along with those things. And so I just wanted there to be an understanding, especially for some of the newer pulmonary APPs that, this lab is associated with this disease. Or if you see somebody in clinic that you make a diagnosis of interstitial lung disease and, you're thinking about additional questions to ask, maybe think about it from an autoimmune perspective of maybe I should ask this person about joint pain, or maybe I should ask them if they have Raynaud's because maybe they have scleroderma or, early scleroderma or something like that. So I tried to make that pretty clear in terms of just some basic, this is what I would want another person to know, maybe even before referring to me, just so that it can be a helpful tool when you're seeing patients to know kind of what potential tests would be helpful for you all and to know when to refer to rheumatology.
Yeah. So you did mention that there are certain diagnoses that you think about that might, influence the lungs. And
Yep.
Which types of rheumatologic diseases are you thinking about when you think about possible ILD within the lungs?
Yeah. So the big ones, and these are the ones that I spoke to, are rheumatoid arthritis, scleroderma, which again is kind of one of those things that I know a lot about, both of you, as well as Sjogren's, and also kind of the inflammatory myositis, so dermatomyositis, polymyositis. So those are the ones that I really focused on, as well as mixed connective tissue disease, which is kind of a little bit of a mixed bag. So those patients can have overlap features. And so I wanted the audience to leave understanding that, hey, these are common things that we see where the lungs are definitely impacted.
Yeah.
Did you list those in a particular order for us?
Yeah, I think I started with rheumatoid arthritis just because that was the easiest, honestly, as I was kind of thinking, and then scleroderma, Sjogren's, and then myositis, and then mixed connective tissue disease.
That's how we kind of would probably see them as an occurrence. Is there more rheumatoid arthritis in the lungs rather than, mixed connective tissue disease?
Right.
Or what would we most find?
Yep.
in
I think
ILD?
that's a wonderful question. So I would say scleroderma is going to be kind of one of those ones that, especially diffuse scleroderma, where it's just so common that I think most of us in rheumatology, as well as pulmonology, kind of think about that. But like for example, that really has kind of come to the forefront in my mind is Sjogren's, which I have to say early, even in my career, I wasn't thinking Sjogren's, interstitial lung disease. Like I didn't put those two together. And in fact, early in my career, actually, now I'm going to date myself. I've been doing this for 18 years, but I remember one of the rheumatologists I worked with was like, oh, Sjogren's, it's just a pretty mild thing and no need to really worry about it. And we would actually tell patients that. And so the more I've learned about that particular disease process, it's like, no, actually, there's a lot of end stage organ damage that can occur with Sjogren's, and then obviously the myositis, dermatomyositis, polymyositis, antisynthetase kind of falls in that, is pretty darn common. And you really need to be, as a rheumatology APP, understanding that we need to be doing some pulmonary workup if we are the ones that are making that diagnosis. But also, again, on your end, kind of thinking like, ooh, I probably should be asking about weakness. Okay, should be asking about inflammatory arthritis, Raynaud's, have they had skin thickening, things like that, just because those are just a lot more prevalent in the inflammatory arthropathies and connective tissue disease.
Yeah. So, Cori, are you looking at patients' joints? Are you asking your ILD patients about their skin, about their muscles, those types of things?
It's interesting because when I first started practicing, I think the concept of ILD seems so big. So as a new nurse practitioner, I think I was afraid to look at people. I know that sounds funny, but actually like visually look at them and inspect their bodies. And on my onboarding, the physicians were doing it. And I'm like, okay, talk to me more about how do I do this well? And I think as an ILD APP, that training is important. Like, what are we looking for? What do we see? What's actually like a swollen joint and what's just like large knuckles?
Yeah.
And I think the interesting thing that I've kind of come across the years of practice is it takes time for us to assimilate, just like it would take time for you to listen to crackles, right? Like, is that crackles? Is that not crackles? And I feel like we don't give ourselves a little bit of breath of space for learning. But I do inspect all of my patients. I'm like, okay, like, let me see your hands. Let's see your skin. What's this weird bump? And they're like, oh, I didn't know. How does that relate? Sometimes I have to look things up still or ask my rheumatology colleagues. It's not always easy for me, admittedly. But I do look at everyone. Do you look at everyone too?
I do. I mean, at some point, if I know I have a well-established IPF patient, I might leave it alone, but
Right.
Absolutely. Yeah. So I take care of a lot of patients with CTD ILD. So we're always going over their joint symptoms, their skin symptoms. Now, interestingly, sometimes joint symptoms being flared don't mean the ILD is flared, and the lungs being flared up doesn't mean that their CTD symptoms are flared up. So, but it's really important to ask those questions. And on the flip side, I don't know, Amanda, are you asking patients when you see them about shortness of breath symptoms, or what types of things are you asking from a pulmonary perspective of your patients?
I love this question because so many people that I have run into, and I'm so fortunate because I've been able to kind of go all over the country and teach and meet people. And it is astounding how many people still don't even listen, don't even have a stethoscope. And I'm not just talking about APPs, right? I actually think, maybe we're a little better, but physicians, don't, they have to dust off the stethoscope, and so, I will say that maybe early in my career, maybe I wasn't as good. Well, I don't know, maybe early in my career, right when I get out, right, I want to never make a mistake, right? And so I'm listening to everybody. I get my reflex hammer out and I test reflexes on everybody. And you do all the things that you learn in school.
Wait, I don't have a reflex.
Yeah, I don't think I've used one since I was in school. Yeah, I don't know.
I don't know where mine is. Really, actually, I think I did find it actually in the toy box randomly. So of one of my kids, but then so I felt like I kind of got a little bit in full transparency, a little lazy in my own practice in terms of like, well, it's just easy to focus on what I'm focusing on. And I think I really started to realize that, I'm missing stuff, right? So then I started listening to every single patient that comes in the room, particularly, I mean, of course, like a scleroderma patient, I would definitely be listening to, but like less likely, like I said, in a Sjogren's patient or even an RA patient, if I'm being honest. So at this point, because again, I know that these are such, there are higher prevalence of these things in my diseases that I treat. I've started really listening and asking those questions. Sometimes it can be hard. I see 20, 21, 22 patients a day. And so sometimes it is hard for me to, open up the can of worms are you feeling shortness of breath? Things like that. But I definitely try to say and no new respiratory symptoms, like you're not having any increased shortness of breath or coughing that's not explained or something like that. So I really do try. Of course, again, the disease entity also kind of, will in some way shape what I'm asking, but I really am listening to everyone. I had a patient that I saw as a new patient a couple of weeks ago, and she came, from kind of in a more remote location. And I just had this feeling when I looked at her that she's going to have some more serious manifestations of rheumatoid arthritis. And sure enough, I listened to her lungs and there's inspiratory crackles. And this patient, she literally would not have told you that she's short of breath. And in fact, even after I asked, I listen and then I'm like, have you had any shortness of breath? No, but this is a hardworking, salt of the earth, farmer that's out doing things on a day-to-day basis. So she's compensated, right?
We call that the rural effect at National Jewish.
Yes. She lives in Nebraska. And so I was like, well, let's go ahead and get a chest x-ray. Let's just get a CT because I hear a little something. And, on that same token, I also learned from you all that just because I hear those things doesn't automatically mean that they have ILD associated with their autoimmune disease. I've sent them to an ILD center and turns out it's because you actually have a bird or some other, entity that has caused your interstitial lung disease that actually has nothing to do with your autoimmune disease.
What a double whammy that is.
No
You've got
kidding.
a rheumatologic diagnosis and now HP from your bird.
Yes. Well, that's just it. Actually, that was a patient that I sat down and I'm like, what?
That's a hard discussion about the birds.
Yeah. These people that have birds, by the way, I don't know if I...
No, they love their birds.
Oh,
they
love them.
do not want to get rid of their birds. They would rather deal with their interstitial lung disease, I think, than get rid of the
Totally
bird.
true. Totally true.
It is.
Absolutely.
I know.
Yeah. So, I just want to make a comment on one thing you said. I think as you become more experienced in your practice, you start to get this sixth sense about you can just look at a patient and know what's going on with them. So that's really interesting. Somebody who's been doing this for 18 years. That's great. If you saw somebody and they were having some more shortness of breath and things, do you ever send them for PFTs, pulmonary function testing, or what do you think in general your colleagues in the rheumatology space are doing, or are you just sending out to pulmonology?
That's a really good question. I think just like you all want to know, what labs are helpful, I try to tee them up as well as I can. I do not claim to be any kind of interstitial lung disease expert. I have certainly found it, but I feel like it's really important that I co-manage these people with you all, as Cori knows, because we've shared patients, and so from my perspective, if I see a patient that has worsening shortness of breath, I generally that day will order a chest x-ray, and then I'm ordering PFTs, and also again, if I'm suspicious of interstitial lung disease, I'm ordering the high-res CT scan. That's about the extent. I'm not doing walk
awesome.
tests. Oh, good. Oh,
yeah,
good.
That's great.
I'm not doing walk tests or anything like that on patients. And, I have to say I still struggle with understanding the PFT PFTs, like that is a weak area. Like to me, it just looks like a bunch of numbers and I still don't quite understand. I do see if people say restriction, then I'm like more, apt to maybe think that they have some kind of connective tissue disease, ILD. But again, I kind of am like, okay, great. Now you can go to pulmonology to have them interpret that because I don't really know what I'm doing.
Yeah.
And that's why collaboration is important. I hope that when I get stuck or not sure what to do with some results that I'm just conveniently ordering to expedite them to rheumatology, that I could really lean in on my colleagues and say, hey, I really don't understand the extent of this. I need your help. And the same for us, if you're like, well, I don't really know what this PFT shows, like lean in and just ask us. We're always here. And I think that's the message we should give to everyone is collaboration is important. And we just need to be more open and available to each other so that we can take care of patients.
Yeah, I love that you asked that because, in fact, I know that you've said that, you have very close collaboration with your rheumatology colleagues.
Yeah, we sit in the same
National
room.
Jewish. You sit in the same room.
I know.
So how can we, as rheumatology APPs and pulmonary APPs, just in general, collaborate better with each other? Over this.
Besides sitting in the same room, right?
If you're not sitting in the same room, it is hard, isn't it?
It is. I think the way that I've taken down the barrier is offer my cell phone and offer that they can call anytime. As inconvenient as that may be for some people, like I have no idea what your work schedule is, and you have no idea what mine is, and to know, hey, I'm available between 7 a.m. and 7 p.m. That's a huge window of time. Most people don't work 12 hours in our field. And so if you can get me between those times, so be direct about when you're available and offer my cell phone. And I haven't had anyone not call me. And that's sort of the way I've gotten around it.
Yeah. Amanda, do you have pulmonary colleagues that you're close with that you can collaborate with? Or?
I do. I'm really fortunate practicing in an area where, we have two very large institutions that both have interstitial lung disease clinics. So it's a bit of a drive for my patients, but I'm fortunate within my system. I'm able to kind of get them in, again, I have, Cori's cell phone and Katie, who used to be in National Jewish, I would text her. And then also, I have some local pulmonary colleagues that I will just reach out to and say, hey, Chris, can you take a look at this for me? I'm not exactly sure. And he's really, really great about responding to me. I totally agree with you. I feel like we really do need to collaborate with each other. I think physicians do this really well because they like meet other physicians like in their fellowship and things like that. But there's so many APPs that are coming out in the field. It's like they're coming out in droves, which is amazing, but I don't get the sense when I meet younger APPs that they have this network that the physicians do. Yeah. At least that's been my experience. And so I feel so fortunate because I have, people from all over the country that are at these like large institutions where I can reach out. And I realize that that's not everybody. But I totally agree. It's so important that we be able to just pick up the phone and say like, hey, like, it's so funny. Like even earlier today, right? Like I see this patient for the first time, like a couple of weeks ago, and she has a history of rheumatoid arthritis, but I kind of looked at her and I'm like, gosh, you don't look like RA. Also has a history of myasthenia gravis, which sounds like that was a little bit of a clinical diagnosis. Anyway, something about her made me say, I better order a myositis panel on her. Like she's already on IVIG. She's already on 25 milligrams of prednisone, can't reduce it. She's on methotrexate. And again, maybe I'm thinking to myself as I'm seeing her, well, maybe that's why I don't see any synovitis on your exam, like any swelling in your joints, because you are, on a lot of therapy right now. Well, she's MDA5.
Oh my.
And so immediately I'm like, this is not good. And so to your point, like I, sent a secure chat or whatever to her neurologist, who then gave me her cell phone. And so like I actually talked to her this morning and I'm like, I just want you to know, like, again, I know I'm really, early involved in her care and I'm not, entirely questioning the RA diagnosis, but I kind of am, from her former rheumatologist. And I just want you to know, I mean, like, how firm are we on this myasthenia gravis thing? Could it potentially have been a myositis? Like, she's like, I don't know. She was diagnosed somewhere else. And I say all of this to just say that, like, that's so important that we talk to each other, right? Because if I had just gone based on her note and not talked to her, I'm missing a lot of the story.
Yeah. I think that's a good segue into why we all should come to APAPP in
Absolutely.
2026.
You read my mind, Cori. I was going to say it.
Of the networking.
That's right.
It's
and
an
RAP.
amazing place
RAP
to
as
know.
well, the Rheumatology APP conference.
Exactly.
Yeah.
It's two things that we should actually, as pulmonary APPs, rheumatology APPs, is share the RAP and APAPP experience together. So I'd say don't miss APAPP or RAP in 2026.
Yes,
absolutely.
I totally echo that.
It's a time for you to meet other APPs who work in your specialty or other specialties and learn from each other and have those connections. So yeah, it's really wonderful. For wrapping up, what about just a couple pearls for our listeners? What would you say to either an a pulmonary APP, about what to kind of look for with respect to either, CTD ILD, or what would you say to a rheumatology APP to look out for ILD in their patients?
Yeah. I think, again, it's just asking the right questions, right? It's asking about the joints. It's asking about weakness. It's asking about some of those kind of scleroderma type of symptoms. I think that's where you start. And, then kind of understanding, okay, I'm suspicious this might be a connective tissue disease, that potentially is causing their ILD. These are the labs that I can order to help me maybe understand that. And then now I do get these labs back. Okay, this is what they potentially mean. So I think that, and then, so I would say that from a rheumatology to a pulmonary, right? The flip is, I would say to all my rheumatology colleagues that they have to listen. You have to listen to people's lungs. Like I became a little bit stagnant, I think, and was not always listening. And so I'm as guilty as anybody else, but I'll tell you what, if you're not listening, you are missing it. You're missing it, because I'll tell you, even when patients say that they're not experiencing shortness of breath, again, so many people, I think, compensate for it or something. And so then you listen and you hear it. And then once you start to hear it, then you see it more. And so that's what I would say to all my rheumatology colleagues. And then also, again, understanding that not all ILDs are associated with their connective tissue. Because again, like the bird situation, I didn't really know that, if I'm being honest. I didn't know there were so many interstitial lung diseases. Like in my world, I'm like, but they're all related. And I realized that they're not. And so I think that's what's important, again. And then lastly, I would just say this kind of what we've kind of said, this cross collaboration, I think, is so important, which is why it is so important that we continue to come to these conferences, because, again, that's how you're going to meet the people from Cleveland Clinic and National Jewish. Like, otherwise, if you're practicing in, Montana, you might not have access to an ILD center, whereas, with you all, like, you can ask those questions and not feel dumb,
What would you say, Cori, about like your ILD colleagues? What would you tell them to look out for?
I think the clinical pearls, like when a pulmonary APP is seeing a patient from rheumatology, is just as Amanda said, that weakness, ask about their joints, and then, definitely pay attention to the labs, ask questions.
I will say, from a person who sees lots of ILD, I mean, if you're seeing a certain pattern on a scan like NSIP, you really, really, really have to raise your suspicion for CTD ILD, and definitely utilize your rheumatology colleagues to help you kind of parse that out. Could this person actually, have an underlying CTD? Okay. So, any other last words, thoughts from you guys?
I think we covered it all.
Yeah.
We covered it all. We've solved
all
CTD,
of the problems.
all the problems, yeah.
And we just, I guess, need to all share our cell phones with everybody.
So, that's right.
And then everyone will be set.
Yeah.
Well, I'll close. So thank you for coming and taking time to listen to how pulmonary and rheumatology APPs collaborate. And we hope to see you at APAPP in 2026 and at RAP in 2026.